Good afternoon. I'm Bethany Saxon, the Director of Communications at the Center for Public Health Law Research at Temple University. Thank you for joining us for the 5th webinar on our Exploring Policy Surveillance webinar series. A few notes on housekeeping before we begin. Our presenters today will spend some time at the end of the webinar answering questions. Please feel free to send questions as you may think of them throughout the webinar. To submit a question, open the Q&A panel using the ellipsis button on the bottom of your screen and select Q&A. Once the panel is open, select All Panelists. You may then type your question and click Send. Our moderator today is Adrienne Ghorashi. Adrienne is a program manager at the Center for Public Health Law Research. She's responsible for managing legal mapping projects on a broad array of public health topics with a focus on reproductive health laws. Adrienne, I'll now hand this over to you.
Thanks, Bethany. Thanks to everyone who's joined us this afternoon for the final installment of this webinar series, Exploring Policy Surveillance. Over the past 4 webinars, we've heard many examples of how policy surveillance and legal data are being used to advance our understanding of the law and its impact on health, well-being, and equity. Our panelists today will further explore how high-quality legal data produced using policy surveillance methods can be used to support policymaking and advocacy. With that, I'd like to introduce our 3 panelists for today. Up first is Corey Davis. Corey serves as the Deputy Director at the Network for Public Health Law's Southeastern Region and Staff Attorney at the National Health Law Program. Next, we have Elizabeth Nash. Elizabeth is the Senior State Issues Manager at Guttmacher Institute. And finally, we have Alex Jones. Alex is a manager for the Local Democracy Initiative at the National League of Cities.
All right, Corey, you can go ahead.
All right. Thanks, everyone. So, yeah, I'm Corey Davis. I'm with the Network for Public Health Law, and I wanted to kind of tee things up here today by talking a little bit about the importance of public health law research and policy surveillance for local and state policymaking and policy change. So I wanted to focus this on my area of expertise, which is sort of state and local responses to reduce drug-related harm, which is something that is kind of a hot topic these days. It's something that I've been working on for a very long time, and you're probably all somewhat aware of it. I'm going to go through it briefly. So it's a serious problem. It seems like for the first year in about 15 years, it may be that overdose deaths did not increase over the last year, but they're still at an extraordinarily high level. We had about 67,000 people die of overdose-related deaths up to September 2018, and that's surely an undercount. It's now the leading cause of death for Americans under the age of 50. It's more people than died at the height of the HIV/AIDS crisis before highly active antiretroviral treatment. And, this is a really frustrating public health issue because, well, for a number of reasons, but also because a lot of these deaths are preventable through a variety of mechanisms. The epidemic has shifted over time, so it used to be largely driven by prescription opioids and prescription opioids in combination with other drugs. The proportion of those has gone down slightly over time. You can see that here. So we've got a rapidly shifting epidemic. You can see this huge increase in heroin-related deaths around 2010. Around 2013, we saw this massive increase in deaths related to fentanyl and fentanyl analogs. Then a lot of these are polysubstance, but it is still a massive change. The only place that we've seen decreases are in methadone, and this is largely methadone for pain. This actually is a policy win. I probably should have a slide on it, but a lot of insurers were pushing methadone for pain treatment as a frontline therapy because methadone is extremely inexpensive. It's generic. It's cheap. The problem is it's the same characteristics that make methadone a good medication for opioids opioid treatment make it dangerous for pain treatment. That is, it's got a relatively high affinity, it's long-acting, and it has a long mechanism of action. It's active for a long time in the body. That makes it relatively dangerous for pain treatment compared to some other medications. We have seen insurers change those policies to move away from methadone as a frontline treatment for pain, and that is, probably what is responsible for that decrease in methadone. Everything else has gone up, which is bad. There are big differences between the states. These are rates. These are overdose fatality rates. These are from, I think, 2016. They haven't changed much since then. You can see that there are massive changes, massive differences between the states in the burden of opioid-related fatalities, which suggests possibly that some states are doing something better than others. It also suggests that there are changes that states can make. Obviously there are a lot of things that the federal government can and should be doing, but there are things that states can and should be doing to try to address this burden within their borders. Note here, Texas is not doing a good job at reducing drug-related harm. Texas is doing a bad job at reporting drug-related overdoses. They've gotten a little better over time, but that's just a bad data there. All right, so let's talk a little bit more about state law and policy. Well, the federal government has done some things. We had CARA, we had CURES, we had the Support Act. But at least in my opinion, we've got kind of a Toby Keith situation. We've got a whole lot of talk, not a lot of action at the federal level. Certainly nothing commensurate with the severity of the crisis. So we've got states acting as we call laboratories of democracy. This is something that we like to see and like to talk about in public health policy. You have one state thinking that something is a good idea. States are able to move faster in a lot of cases than the federal government, and they implement a policy or practice, and then we're able to see what's happening. Unfortunately, a lot of states are following this logic. Something like, we need to do something. We're hearing from our constituents this is a big problem. Everybody wants us to do something. We need to do something. Well, here's the thing. So let's do it. That's how a lot of state policy change has happened in this area over the past few years. And that's true of, you see that with a lot of issues, but I think that it's even more true with this one than others, because there is just this urgency to make it seem as though something is being done. And it's happening against, a backdrop not of not only a lack of evidence, but a continued unwillingness to spend money, to really change existing structures. So you see a lot of nibbling around the edges in the states. And of course, this isn't a great way to go about doing things. It's a complicated problem. There's a lot going on. You've got social determinants. You've got a lot of proximate causes of substance use disorder. You've got a lot of ways of keeping non-fatal overdoses from turning into fatal overdoses. There are a lot of ways of reaching out to people who have had a non-fatal overdose, connecting them to care, and so on. There's a lot of moving parts. There's a lot of things states can and should be doing, and it's complicated. But it's important to try to get it right. So how do we do that? Well, in public health policy, one thing we can do is we can look at these laboratories of democracy. We can see what other states have done, and we can see, whether it has worked or not. Are states doing that in this context? I'm skeptical. I'm skeptical. I still see a lot of policymaking in this area being driven more by people falling back on their priors, to some extent by what I think is largely misguided guidance. by the federal government regarding things like prescription drug monitoring programs. And you just don't see very much of that policy learning, at least so far, unfortunately. So let's talk about that a little bit. Think about prescribing limits, PDMPs, and syringe access. So over half the states have now implemented some sort of limitations on the prescribing of opioids for pain. Most of these have been implemented in the last 2 years or so. We're now up to about 30 of these states. 23, 24 are new since 2017. They vary in their specifics. Most of them are limited to acute pain. Most permit the prescribers to sidestep them. Very few are limited or say anything really about polypharmacy. They don't take into account things like co-prescribing of opioids, benzodiazepines, even though we know that polypharmacy is a huge driver of opioid-related risk. None go back to that point of the prescriber's decision to prescribe an opioid or not, at least not directly. None of them say, okay, the Cochrane Collaborative says that for this particular condition, NSAIDs are as effective on average as opioids, so we want you to prescribe NSAIDs first. None of them do that. They only come in at the point where the decision to prescribe the opioid has already been made, and they put limitations on that decision. So states are, approach this in slightly different ways. Most states have day limits. You can only prescribe a certain number of days worth of an opioid for acute pain. A week seems to be the mode. Here you've got a few states that are shorter, a couple states that are longer. Some limit dose. This lowest effective dose language is right out of the CDC guidance document. Some have very low limits. Ohio and Rhode Island are at 30 MME. In other states like Maine is 100. To prescribe 100 MME right off the bat to someone with acute pain and no previous opioid prescription, who is not post-surgery, is actually kind of rare, so I'm not sure what, if anything, that's doing. But anyway, do these things work? We have no idea if these things work. As far as I can tell, nobody is even trying to determine whether they affect opioid-related prescribing, much less other measures of harm. The idea behind these is this, I think, totally taken out of context idea that if you look at this thing called the National Survey of Drug Use and Health, it'll tell you that a large number of people who say that they've misused opioids got them for free from a friend or family member. So the idea is there's this huge just pool of opioids sitting around in medicine cabinets just waiting for people to take them and become dependent or addicted. That's not how the real world works. Fewer unnecessary opioids sitting around in medicine cabinets is on net a good thing. But this is just not. That's not how it works. Like I said, there are potential problems with how these things are operationalized. One thing that we don't know is whether they are going to move some people from prescription opioids to heroin. We don't know. We don't really know anything about these things. Has that states are influencing them? No. This is the new hotness. Everybody's jumping on this bandwagon. Prescription drug monitoring programs, I'm sure most people on the call are familiar with these things. What's the logic model behind them? Well, you collect data, and then who knows what happens from there. What's the ultimate goal of prescription drug monitoring programs? Well, it depends on who you ask. If you look at state laws, which I have, you tend to get things like reduced doctor shopping, reduced diversion, assisted investigations, that sort of thing. Prescription drug monitoring programs were not designed and are largely not implemented as public health interventions. They're really not focused on public health outcomes. If there is a state that uses prescription drug monitoring programs to identify, quote, doctor shoppers and then dispatch public health nurses or peer navigators or someone else to those people to say, hey, it looks like you might be a person at increased risk of drug-related harm. How can we help you reduce that risk? I haven't heard of that state. It seems like an extremely obvious way to use a PDMP, but they're just not designed that way. They're not funded to do those things. So largely they don't. Do they work? Well, this is the most recent comprehensive review that I'm aware of, and we have Mr. Shruggy Face here. Hard to tell. There's some evidence that they may reduce things like doctor shopping and so on. Doctor shopping is not a public health outcome. If you have a person who has opioid use disorder, who is accessing a lot of prescription opioids, and you take away their risk of their source of prescription opioids, and you don't connect them with evidence-based treatment, you have turned a person with a prescription drug problem into a person with a heroin problem. And there's pretty good evidence that some PDMPs are doing that. There's really very little evidence that they are associated with reductions in drug-related harm, at least net. Has that stopped states from influencing them? No, of course not. One of those things that has tremendous evidence base. It is often shorthand that heroin use is a risk factor for hepatitis C or for bloodborne disease infection. That's not true. Lack of access to new syringes is a risk factor for bloodborne disease infection. So we know that getting people who are injecting drugs, sterile syringes, clean syringes, new syringes, is a way to reduce bloodborne disease infection. But, even just the most basic way of doing that through syringe access programs, which are good, but certainly not best practice. There's only, depending on how you count, 19, 20, 21 states that even permit these syringe access programs, and they're nowhere nearly sufficient to meet the need. And we have, there have been a couple of states, there have been 9 or 10 states over the past few years that have passed laws permitting syringe access programs. Those laws are not based on best practices. They're not very good. But yet that's what's been going on. What we should do is decriminalize syringes. There's no reason that syringes should be criminalized. It serves no public health purpose. It serves really no public safety purpose, but that's not what states are doing either. All right, so what does this mean? Well, like I said, it seems like states are running around trying to do something. They're like Alice in the forest where she's talking to the Cheshire cat, and she says, where should I go? And the cat says, well, where do you want to end up? And Alice says, well, it doesn't really matter so long as I get somewhere. And the cat says, well, and it doesn't really matter which way you go. That's not a good way to legislate. We really need to be thinking about where we want to get to and work backwards from there, right? So if our goal is to make it seem like we're doing something, that's fine. We're doing that. We're doing things, and that's great. But that's not a very good goal. It's not a good public health goal. So, if our goal is to, reduce bloodborne disease infection, for example, we need to work backwards and say, what are the vectors for bloodborne disease infection? How can we reduce or eliminate those vectors? And then you implement laws and policies that seem directly designed to do those things. And that's where, states don't really seem to be doing that. And it's quite frustrating. And I think that part of the problem is that we in public health aren't doing a good job of framing things in that way, particularly here in, and I consider myself to be at least part-time a public health legal, researcher. And I think that by and large, we start out on the other side. We start out with the law, and then we look to see, what, if anything, is the law doing? That's the wrong way to do it. We need to be starting out on the right-hand side of the logic model and say, okay, here's where we want to get to. how can we design laws and policies that are likely to get us there? And when people come to us and say, well, what we're going to do is we're going to identify doctor shoppers, and say, okay, that's great. That's not a public health goal. What's your public health goal? And can you explain to me how that thing that you've identified as a goal, how it fits into the logic model that has on the right-hand side a public health goal of, say, reducing drug-related harm, and what evidence can you point to suggest that what you're suggesting is actually going to get us there? Yeah, so again, this is, in the context of opioid-related harm or drug-related harm, but I think it's applicable generally to lots of sort of public health issues. That we need to be thinking about how are the laws and policies either, on the books or in practice going to get us to where we want to be, and are they? And if they're in really holding the policymakers' kind of feet to the fire a little bit and saying, can you explain to me, what you think this law is going to accomplish and how you think it's going to accomplish that, and point out to them some, possibly better laws and policies that are going to get them to where they want to be, if they actually want to be there. If they don't want to get there, that's fine too, but they should be willing to stand up and explain to their constituents that really their main concern is not alienating the law enforcement unions, for example, and that's more important to them than saving lives from overdose. That's fine. Everybody makes decisions as they move through the world, but I think they should be more clear that that's what they're actually doing. All right, so I think that's where we are. Law and policy matter. They're complicated. The data aren't that great. Things like PDAPs and Law Atlas, I think, have made great strides in making, providing better, more comprehensive, more timely data, and that's great. But the question is, how do we translate that into action? Unfortunately, I don't have great examples for that, but I do have some thoughts, and really that is, largely people, community members and people, us in public health, being more assertive, really sort of foregrounding the public health goals of laws and policies, and really making sure that the laws and policies that are implemented at least seem likely to get us to those public health goals that we want to get to. And with that, I will turn it over to Elizabeth.
Hi. Thank you, Corey. That was amazing. This is Elizabeth. I hope everyone can hear me. Okay, I'll go with that.
You're great, Elizabeth. We can hear you for sure.
Excellent. Thank you. So hi, everybody. I'm Elizabeth Nash, and I'm a policy analyst with the Guttmacher Institute. And I'm really happy to be here today along with Corey and Alex. As I was listening to Corey's presentation, I was thinking about themes in the work that I do around abortion laws and recognizing there are some similarities, particularly about the thorny patchwork of state laws and state legislators adopting policies without understanding any kind of impact, or and just the fact that abortion can be a very frustrating issue to work on, and also that it has been a hot topic for many years. So with that, we'll kind of dive right in. So in fact, abortion has been a hot topic and one being heavily debated this year, but it's been really a hot topic since the U.S. Supreme Court affirmed the right of abortion in 1973, as well as a lot of action in the courts. And we have seen less action at the federal level. And so when we start thinking about this database on abortion laws, we're really thinking about filling in gaps in knowledge because of this patchwork that really varies whether you're talking about Vermont, Louisiana, or Illinois or California. So nearly every state has at least one law on abortion that affects provision and access. There are really only a couple of states that don't have any kinds of laws. So, and the landscape is incredibly confusing. There isn't a lot of uniformity on the abortion laws, even when they're on the same topic. So many are badly drafted, so much so that they really require interpretation as well as understanding all the other abortion laws that are in effect in a state. And everyone, I'm guessing on this call, knows that abortion continues to be this political football. So we typically see a couple of dozen changes to the laws every year. And over the past 8 years, we've seen 33 states enact over 400 abortion restrictions. And I say that as a way to give you a sense of just how much things change at the state level, and they change constantly. So, we get these amendments, and, oftentimes these amendments are on existing restrictions. So we're seeing amendments to a waiting period. So maybe a 24-hour waiting period becomes a 72-hour waiting period. Or a state that had required a young person under 18 to have parental notification, right? The provider has to send out a notice to the parent. Now that state is going to require parental consent. So what does all of that mean in the context of providing care and ensuring that patients get access to care? And sort of that third point on the bullet, right, slide, court cases, right? I was able to use C, the letter C a lot here. So court cases, the legal system is heavily involved in the status of abortion laws. Several court cases are filed every year, but it's not always true that if a state challenges an ultrasound requirement or a plaintiff challenges an ultrasound requirement, that requirement will be struck down. Sometimes they're struck down and sometimes they're not. So, and sometimes parts of the laws are struck down and sometimes not. So all of this moving and amending makes it very difficult for advocates, clinics, patients, attorneys, everybody to keep up. And it's very difficult for us also to see the impact on either individual or collective policies. So we could actually see whether a restriction or a policy, what kind of impact does it really have? Is it always a negative impact? Could there possibly be some kind of positive impact? And what happens when you combine the impact of different restrictions? And so what do we really need to ensure that patients are getting the care that they need in ways that is aligned with medical practice? So just to show that this was a robust group that worked on this database, we pulled together 6 reproductive health groups, some of which you may be familiar with. All of them work to protect abortion rights and access across the country. And we joined up with the Policy Surveillance Program because, right, they're the ones who help us understand health policy in a more comprehensive way, and they have their ways of researching the laws that is incredibly comprehensive. So we really identified 4 audiences that were in need of this kind of database. And so it's probably not surprising that we're putting abortion providers at the top along with their attorneys. They need to know what's in effect so they can comply with the law and continue to provide the care to patients. This database was made public just in January, and not really to pat ourselves on the back, but to know that it's been really gratifying to know that the clinics are using the database for the purpose of understanding their own state laws. And so, for example, I was talking with some folks a little while ago, and they were talking about how they were using the information on minors' access to abortion to ensure that they had all the legal boxes checked off and fulfilled so that they were fulfilling, the legal requirements, but also doing it in a way so that their patients could get the care that they need. And this is particularly important for young people because oftentimes the states do have these parental involvement laws, but also because younger patients might have other barriers that they're facing around funding for abortion and being able to get to the clinic. So, and it's also important so that clinics can see what kind of laws are in place so that they can figure out if complying with the law is not possible, and what kind of legal routes are available, either amending laws, going through the court, the state house, litigation, which is a pretty big one in this field, or working with the health department to try to figure out a way to be able to comply with a law or regulation, and in a way that suits the clinic. And this, of course, brings us to the litigators. They have to do, when they're bringing court cases, they have to do a lot of legal research to understand the laws, not only in the one state that they're bringing the lawsuit in, but also similar laws in other states, and understanding the court cases that have followed from those laws. And so this database really gives them the information that they need when they need it, and they don't have to spend a lot of billable hours to find all of the information that they need. And sort of the third pillar here is really the advocates. Advocates have been using this database since it's been up in January to help them identify, states that may, if they're working on a bill in their state, they use the database to find other states that already have a law in place, and to talk with folks there about how it is or is not working, what kind of arguments was used generally against the restriction, that kind of thing. So the database is really giving them that information quickly. And then researchers are using the database as a tool to help develop new projects on the patient experience, to try to identify new ways of doing research so that they can better quantify what it's like for patients in clinic when these restrictions are in place. But there are so many restrictions and everything in place, restrictions, regulations, court cases, that we really had to develop a pretty detailed and comprehensive set of issues to be able to provide information about all of these laws at one time. So what we did was we identified 12 areas to focus on, as well as a 13th overview data set. Now, these data sets cover everything from how an abortion clinic can advertise, because there literally are restrictions on how abortion clinics can advertise their services, to when in pregnancy abortion can be provided, to how long that waiting period is. And then we added in 3 data sets that were developed earlier. Those are the ones in blue that focus on clinic regulations that cover like the physical plant requirements, such as like hallway widths, as well as requirements on staffing and equipment. So what kind of staffing do you have to have in place, nurses versus APRNs versus anesthesiologists versus physicians or physician assistants, as well as equipment standards, what kind of equipment needs to be in place in the clinic, and what kind of emergency equipment, for example, needs to be in place. So I would like to point out that the shortest title bans is what's one of the most important issues, especially this year. This issue covers gestational bans, such as 6-week or 20-week abortion bans, as well as state laws that ban abortion methods. And then there are states that have multiple bans along with court cases. So being able to clearly outline all of those details so that providers know when abortion is legally available is key. So, for example, some states may ban abortion at 22 weeks after the last menstrual period, but also have restrictions for post-viability abortion. So really being able to understand all of that at one time becomes incredibly important in those states. And so I'd like to close out with a short example from the waiting period. So this is kind of what the website looks like, right? A short example from the waiting period data set. And so abortion counseling and waiting periods are pretty complicated. In many states, who does the different sections of abortion counseling is detailed down to like provider, abortion provider, referring physician, counselor, other staff, and sometimes the counseling is split up among these different people. And so in some states, the provider actually is the abortion provider is required to handle some of the counseling. And this becomes complicated because many times abortion providers travel, or the abortion clinics open abortion services are only provided one day a week. So ensuring that you have the same provider who does this counseling or this ultrasound as the same one who's going to be there next week requires a lot of coordination on the administrative end, as well as what if the travel schedule gets disrupted, or what if the provider gets sick, or what if the patient gets sick, or what if the patient has to come back potentially on a different day? Will that same provider be available? So those questions are of paramount importance to clinics as well as patients, advocates, and everyone else who gets knee deep into these kinds of issues. But also, we have information on here around the issues of content and what exactly must be communicated to the patient, and if the counseling must be provided in person at the clinic, as well as if information must be provided in like a private area. So really there are just multiple factors involved. And so, in this database, I think, so you can see here that, I really identified Idaho as a state where the provider has to do the counseling. And that can make things very difficult. Idaho is a pretty rural state. And so being able to move around, especially in the winter, where sometimes some of the roads up in the panhandle are blocked off, travel can be really dicey. So anyway, so I kind of picked that to give you a sense of the kind of nuance that this database provides and why it's so important for this information to be made public, because there's so many different audiences that need it, as well as using it for not just provision of services, but for thinking about evaluating services and the impact it has on patients. And so with that, I'd like to turn it over to Alex. So thank you.
Thanks, Elizabeth, and thanks to thank you. Thanks, Elizabeth. Thanks, Bethany and Temple for inviting me to talk today on the work that NLC is doing with the policy surveillance program. So I'm going to talk about kind of a little broader topic here, preemption of local authority at the state level, and some of our efforts around tracking and measuring impacts. So, just first to set the table on who NLC is. So we're the national association that represents cities, towns, villages, municipalities around the country. We have over 2,000 members and over 200, representing over 200 million people. And so kind of in that role, we wear two hats, right? We're both an advocate here in Washington, D.C. on federal policy, and then we also do policy research and best practices for our members. We were founded by our 49 what we call state municipal leagues, and that's your interesting fact of the day, that Hawaii only has one city, so they don't actually have an association of cities statewide. But typically those state leagues are the ones who kind of do state level policy and state level legislative advocacy. But a couple of years ago, about 2 years ago now at this point, those leagues came to us kind of with the understanding that a lot of the difficulties that they were facing, the challenges they were facing in their relationships with their state houses weren't unique to their state, and were instead kind of systemic to a broader trend of the increasing what we call kind of the abuse of state preemption. And so, just for background, preemption, it's just a legal tool. It's the use of state law, can also be federal law, but here we're talking about state law, to nullify municipal ordinance or authority. And it's important to note that especially in the public health field, preemption can be a very valuable tool. It can be used to solve some very real problems. Some of the best examples are around protecting fundamental human civil rights, often solving kind of collective action problems at the local level for smaller levels of government. But what we've found and what we've kind of heard is that increasingly preemption is being abused by state governments, and it's being used to kind of halt the progress of policies that we believe to be promoting of public health and health equity. And for us, obviously, at the National League of Cities, we're very protective of kind of local decision making itself. And interested in kind of tracking any infringement on that. And I'll just say, that's for a few reasons from our perspective. One, we think that, just even the current moment today is a time when cities are facing an increasing number of challenges that require policy solutions, and they are eager to be innovative actors, whether it's around things like environmental resilience or economic inequality, or even just being at kind of the forefront of understanding, the importance of building a culture of health locally. And a lot of the levers that we've seen be effective in promoting population health are as a result of local policy action. So over the past 2 years, NLC has done some survey work around preemption, looking at a number of different policy areas that we believe impact things from public health to economic opportunity to just the fiscal stability of cities. And I think it's a great example of kind of a field that's fairly new and really demands a lot more specificity than is out there. So I'm just going to go through a couple maps here that we put together here at NLC that just frankly pretty quickly became some of the best information around this stuff. But what you'll note is that, tracking preemption here is really just a binary exercise. It's really, either a state has preempted local authority or hasn't. And in the case of minimum wage here, this is very popular information, but you're losing a lot of information beneath this. What is the minimum wage within the state? Are there are there more details around what that preemptive law allows or doesn't allow cities to do? But the fact is that this is where the field is at, and even this kind of information became really valuable for our state leagues and their state advocacy to be able to take around. I'll just click through these, a little fast. Paid leave is obviously another one where cities are starting to legislate around mandatory paid sick leave for private employers, and in response, we're seeing a lot of states restrict their ability to do so. Ride sharing has become a very popular area very quickly for states to restrict local policy making, especially concerning for us, considering this is a kind of policy area where cities have traditionally retained authority around, for example, taxi regulation. And again, this is a great example of a policy area where this kind of binary legal data really you lose a lot of the detail, both with ride sharing and home sharing. Airbnb regulation is a very similar area. Two states on here might both have preemption, but in some cases that preemption says that business is not allowed to operate in the state regardless of local regulation, or it may be that business is allowed to operate in the state without any local regulation being allowed. So just a good example of kind of the lack of detail that kind of the first attempt at tracking this trend faced. Just another one here around municipal broadband. This is just to give you a sense of kind of the breadth of policy areas that we were tracking here at NLC. And then finally, one of the areas where we took a crack at providing some more granularity around fiscal authority and tax and expenditure limitations, which we think is extremely important for local government capacity. Here you can see there's a little bit of some specificity around the different levels of limitations, but still just not enough to really be able to do any evaluation or cross comparison. So So after, we've been doing this over the past year or two, we engaged Temple in partnership with the Robert Wood Johnson Foundation to create a much more granular and specific legal data set around preemption laws. So, we are in the middle of this effort now. But ultimately, the goal is to have a longitudinal legal data set that covers at least, at minimum, 11 different policy areas that we believe are related to, either economic opportunity or health equity, and really be able to dig into what the actual impacts of those preemption laws are. Here I just have, kind of an example that's in development. I'm sure everyone here is very familiar with what this looks like, but it's just very important to note that this is far beyond a lot of the field around preemption now. There are some very specific policy areas that have been around for where preemption's been around for a long time. Tobacco control is one of the best examples here, where both some independent organizations as well as the CDC have done some more in-depth tracking on what preemption laws actually limit or enable at the local level. Gun control is another one where there's a little bit more specificity. But, when we did a survey around the country of all the different tracking efforts that are tracking state-by-state preemption, there's around 31 policy areas covered where there's kind of a prevalence of preemption, and it's really only a few where there's any data available to get under the hood on what those preemption laws actually mean in practice. And so over the next couple months, the Policy Surveillance Program will be digging into this current list of 11 policy areas, which kind of span a few different areas, around housing, employment and labor regulation, some things around, obviously, firearms, and then really a focus here on the back end, as you notice, really digging into the impact of tax and expenditure limitations placed on local governments. And this is really important on both sides, both how local governments are able to raise and spend revenue. I mean, there's some direct implications here on issues around public health. We've seen the expansion of preemptions that specifically target things like sugar-sweetened beverage, local taxes. So this is the set we're moving forward with, and I will say that data set will be public later this summer, probably around a July-August timeframe, and we'll obviously be spreading that widely. And then I just wanted to kind of, make a few comments on why preemption is something that really demands the policy surveillance methodology. The first reason is the one that really got us into this as an organization, which is the ability to facilitate cross-state conversations about these laws. Certainly one of the things that we've heard from our state level folks is that these laws pop up in one state and then really quickly spread. But it's a lobbyist in one state isn't paying that much attention to what's happening in other states. So we wanted to be able to provide really, really clear evaluations of these laws as they emerge, kind of in different states, both to kind of give them some help with their own current advocacy, but also looking ahead to the kind of future laws that might be coming down the pike in their state. A second really, really big one for us is to start to encourage more research, both about what kind of the inputs to preemption are, what are the structural reasons that we see some states being really aggressive about constraining their cities, but also the impacts of preemption. And so there's research starting in both of these kind of areas. On the one hand, we've seen some good research that shows that this isn't purely a partisan issue. There are actually some structural reasons why some states seem to preempt at a higher level. But in all of this research, the kind of the preemption variable that's getting used is really just that binary, did the state preempt or did it not, when we think that being able to do research that looks at the whole breadth of the law that's actually passed will give us a lot more detail and insight into, frankly, the politics and the structure behind its passage. And then the impacts of the laws themselves are extremely, important to us and both to understand and to use as an advocacy tool. And so we will be, really aggressively trying to put this data set in the hands of researchers. And one of the things that we've found in our conversations, we're obviously in touch with a lot of the public health law community, but, there's also folks, in urban policy and in local government research, political science, who are really interested in these questions, but they just lack either the competency or the capacity to build this kind of input data set for this research. And, we've gotten great interest expressed from a lot of those folks who want to do this work, but just don't have that, the legal knowledge to be able to look at these laws and disaggregate them in any kind of meaningful way. So it's really delivering this to what is a really multidisciplinary field. We think that the data set that we're building along with Temple will be really, really helpful. And then just the last thing I'll say, to wrap up why this is so important for us, and I think it speaks to the importance of policy surveillance in general, is that there's just a fundamental level of transparency about these laws that we think is extremely important for the advocacy, for the research, but even just for communicating, for our members and for local leaders to be able to communicate to their residents. As somebody said earlier, I manage the initiative here. It's called the Local Democracy Initiative. For us, this is really an issue of local democracy, and what the abuse of preemption is doing is kind of eroding people's trust in the ability of local leaders to deliver policies that they have expressed, a want and a need for. And it's really hard for local leaders to talk about preemption. State preemption is the issue here. And we want to be able to get under the hood and really give them the ability to talk about the practical impacts of these laws. And, just the current state of the conversation doesn't allow that. But when you can, put this kind of tool both in their hands, in the hands of researchers, in the hands of other advocates who can use it to talk more specifically about what this really means for local policy making, and get it out of this kind of conversation around intergovernmental relations, which is where it sometimes falls, and get it more into a conversation about how there are cities out there who have significant challenges, but they don't have access to the tools they need to be able to solve them. And that's where we want to push the conversation, and being able to have really, really clear kind of legal data that points in that direction is extremely valuable for us. We hope it's really valuable for other advocates, and then also for researchers who are ultimately gonna do the work, figure out how these laws impact outcomes in places. So I'll stop there and turn it back over for questions, I believe.
Thank you, Alex. Thank you, Elizabeth, and thank you, Corey. At this time, we're going to go ahead and open up the question and answer session. If you would like to ask a question, you can go ahead and open the Q&A box down at the bottom using the ellipsis button. Select all panelists and then type your question and click send. Adrienne, go ahead. Oh, all right. So, yeah, go ahead. Why don't you start us off then, Adrienne?
Okay, I'll start off with a question while we wait for people to enter their questions into the chat. Alex, I was very curious about your preemption project. Is preemption ever a useful tool at the state level, or should we always leave it up to cities?
It's a great question, and I think kind of speaks to, just to bring it back, it speaks to the need to get under the hood on what preemption actually does, and that's why these kind of just binary preempted, not preempted data sets kind of obscure the conversation. So there's a lot of different opinions here. Where we land at the National League of Cities is that a lot of really effective statewide laws have set it's called kind of setting a floor for regulations across the state that cities then can kind of build upon, right? So that basically ensures that some minimum level of protections, whether it's around environmental or employment regulations, there's some floor that's guaranteed for everybody. But then given local preferences, we like to see the policy space available for cities to go beyond that. What we're kind of seeing in some places, in some of the cases that I put up on the screen, is what folks would refer to as ceiling preemption, where you have a state house kind of dictating that they are going to set a regulatory standard above which local folks cannot go. So minimum wage is obviously the clearest example here, where a state minimum wage could either be a floor that say Seattle wanted to build upon because they have different local cost of living, for example, or just different local preferences. But in other states, we have a statewide minimum wage that it's expressly a ceiling where cities cannot go above. And really what you're doing there is you're limiting the policy variation across the state. Because a ceiling is just de facto kind of the only kind of regulatory regime that folks within that state can live under, because there's no option to go below that, obviously. So it's obviously it's a nuanced question, and we have some thoughts on it, but it again speaks to the importance of getting under the hood of what these preemption laws actually allow. And what they put in place of the local authorities that they're removing.
Fascinating. Thank you. Corey, this question's for you. You mentioned in the beginning of your presentation that these deaths related to opioid use are preventable. And when you said that, were you referring to policy initiatives or something else in order to be able to prevent these deaths?
Yeah, good question. Well, so it's complicated, right? And you can kind of think about an entire continuum, right? So you've got all the way through the life course, you've got people who who are maybe teenagers or whatever, who have never been exposed to an opioid or other drug, all the way to people on the far right side who are, experiencing an acute overdose. And, all throughout that continuum, there are opportunities to intervene, to reduce risk that the person will become dependent, will become addicted, all the way to, to the overdose. There are policies we can put into place to make it more likely that the overdose reversal medication naloxone is on hand. And then post-overdose, there are things we can do at a policy level to make it more likely that evidence-based treatment is available, that people will be, offered and retained into that treatment. So it's, it's both, right? These are interventions. There are a number of interventions, but there are policies that make it more or less likely that those interventions are going to be in place. There's also throughout that entire continuum, structural determinants. You're much more likely to, everything is complicated, but at the population level, people are much more likely to have all kinds of health problems, including substance use disorders, if they have adverse childhood experiences when they're younger. And there are lots of policy interventions that make it more or less likely that people are going to have traumatic childhood experiences. So it's both, right? I mean, some of these are specific interventions, but interventions don't just happen or not happen. They're the results of specific policy decisions that are either being made or not being made. I hope that I'm not sure if that actually answered the question, but that's how I think about it.
No, absolutely. Lots to think about there. So we do have a question from the audience. I'm going to read it. I work in a local health department that is trying to define its role related to policy research / surveillance. I would be curious to hear from each of the speakers how they work with local health departments or how they would like to partner with local health departments.
You guys are all unmuted, so feel free to jump in where you'd like.
Oh, the magic of the webinar. Hey, it's Elizabeth. Is it okay if I go first?
Please.
Okay.
Yeah, absolutely. Go for it.
Okay, cool. So here at Guttmacher, we do work with clinics in a lot of different ways, and some of that is around, patient experience, but some of it is on how, the policies have forced providers to change their practice, and how can we document that. So typically what we do is we work perhaps within 3 or 4 states, and then work with all of the health clinics within those states that want to work with us. We try to get everybody. But usually it's on a very specific kind of intervention or research question. So I don't know what state this person is from, but I would be happy to talk more about the kinds of impact studies that we do. Like right now we're doing a study with on the impact of family planning services and restrictions on services in a handful of states, and so working with a lot of clinics there. So anyway, happy to talk more with the person.
Alex or Corey, do you have any thoughts?
So I can jump in. This is Alex. NLC is a very broad organization, and we do a lot of kind of capacity building work at the local level, and have a whole kind of institute that does a lot of health focused work. I will just say, from my kind of portfolio, I've talked to a lot of local health departments, and where they can be helpful on the preemption space is obviously as advocates for kind of evidence-driven local policy, and just to their state legislatures, and also just kind of emphasizing the importance of both variation and experimentation. I think there's a lot of times frustration when you're kind of handcuffed in terms of what policies you're able to pursue, and so being kind of insofar as you have the space to being an advocate at that state level to at least share your story is really important from our perspective.
That's cool. Yeah, I'd agree with that. I mean, I'm not sure exactly what the requester is asking. I mean, I know that I think maybe it was PDAS, has partnered with some localities to help larger health departments catalog and get a better sense of laws and policies and regulations around a particular issue within the jurisdiction, which can be helpful just to help folks get a better sense of what the policy environment actually is in the locality. I'd say for smaller areas that may not be as useful, I think about this as kind of helping, looking for other places that have done this well, and connecting, folks from one health department with a health department maybe in a different part of that state or even in another state who has dealt with a particular policy problem, who may not necessarily have solved it, but who can talk about, the barriers and facilitators, and here's what we here's what we thought seemed to be working better, here's something that, we'd recommend you.
Thanks, Corey. I think we have one more question, maybe for Alex, about preemption. Oh, hold on just a second. We're trying to see it. That's it. We're going to try and translate.
I think cities are announcing are announcing their plans to enforce ordinances for the first time, but these ordinances conflict with express state preemption statutes, an example being in firearms regulations in Pennsylvania. Does NLC anticipate legal challenges in this arena?
Yes, I think this is in reference to Pittsburgh and Philadelphia, kind of moving ahead with some local firearms regulation, and I'll kind of zoom out and just give a brief comment on the legal challenges that we've seen that happen, that are kind of increasingly happening, where local policy is either newly enforced that conflicts with state level policy, or is kind of advanced in response to state policy that has been added after local policy has been passed. So just kind of, in general, a lot of the conversation and a lot of the developments around the state-local relationship and some of these preemptions is occurring currently in the courts, and there's been some interesting decisions. Obviously, a lot of cities, most cities in most states are protected under at least some form of home rule protections, which gives them what's referred to as, it's probably mostly lawyers on the phone, so, initiative and immunity in terms of what policies they can advance. Those kind of protections, which are at this point, 100 years old in some states, have been eroded a lot by court decisions. But that's, we're starting to see some decisions that are going the other way. We would say, as some of the preemptions at the state level have become somewhat overreaching and in some cases punitive to local policy. And a few of the areas, this isn't directly relevant to the gun control question, but there's some areas where cities are starting to get favorable rulings, in cases where the state has kind of unfairly targeted a single policy in a single city, and that's, in most state constitutions there's some general law restrictions. We've also seen, Pennsylvania has a very unique amendment in its constitution, and actually in the past couple of years there was a ruling around local fracking bans that used the environmental rights amendment in Pennsylvania to say that local governments were empowered by that constitutional amendment to be stewards of their local environment. And then we're even seeing in some court cases the use of the U.S. Constitution itself, the federal Constitution, national Constitution, to potentially be an avenue to challenge some of these preemptions, especially in cases where you have majority-minority cities passing local laws that are then overturned by a non-representative state legislature. So, this is just to say that it's obviously express preemption is really a high bar for cities to overcome, just due to the fact that they are obviously creations of their state, but that there are legal protections for local governments that are, both enshrined in some of their state constitutions or state statutes, but also we're even seeing in some cases that there may be levels of overreach that start to become federal constitutional issues. So it's certainly an area to keep an eye on, and I think we're seeing increasing levels of conflict, both because of the rise of these preemption laws, and also obviously kind of increased policy-making activity at the local level. I hope that's responsive.
Great, thank you. And we'll have one final question, and this is directed towards Elizabeth. Something that you said during your presentation really struck me, which is that in the arena of abortion laws, it's just hard to keep up with how many, laws, amendments, court cases are happening in this area, and then being able to see the impact with the pace of all those laws being passed in conjunction with the court challenges. So how does something like the Abortion Law Project help us to be able to get to where we can see the impact of all these restrictions?
Oh, thank you. Yeah, keeping up with everything is pretty difficult. So I think the first piece is that the abortion laws database kind of does that for you, right? It helps, it keeps up with everything, and it gets updated twice a year, so it's pretty current. The second thing that it does is it really just allows people to be able to see where these laws are in effect so that they can start to think about how they're impacting the patients and putting in that context of the patient experience, because we know abortion clinics are not particularly plentiful across the country, and so the patient experience is already affected by the fact that we don't have a ton of abortion clinics. And they're not open like 9 to 5 every single day. They're open 1 day a week, maybe 3 days a week. So, right, so you have that patient experience, and then you have to overlay all of these policies and figuring out how they affect the provision of medical care, and whether that is a helpful thing or a not helpful thing is really helpful by having this database that sets out all of the laws for you, and you can see how they are going to work together or not together. So yeah, having this database is just incredibly important for being able to, build the case for doing research that can really explain how these laws are affecting how medical care is provided. Does that help?
Yes, awesome. Thank you so much, and thanks to all of our panelists. And thank you for everyone joining us today, and to those of you who have joined us throughout the series of webinars. We want to remind you that the slides and a recording of this webinar, as well as the others in this series, are all available at phlr.org and can be found on the same page where you registered. We hope these will be a valuable resource for you in the future, and thanks again for joining us.
Thank you to our presenters.